As Saad mentioned, in the MRCP, it's IPMN. So it has multiple cysts communicating with the PD, and the head one is 3.5 centimeter. So now our aim is to go and to do an FNA of the cyst that is larger than 3 centimeter. So starting from 45 centimeter from the incisors, just below the GE junction, my hand is open, so I'm starting at the left lobe. So just going a little bit clockwise, then we see the left hepatic vein. More clockwise, we can see the middle hepatic vein. More clockwise, then we can see the right hepatic vein. I'll just show it, yeah, this one, and going into the IVC. And then I just push in a little bit, so I can see the hilum of the liver, and we can see the umbilical portion of the portal vein, trying to delineate the portal vein, so I can see now the portal vein. I will use the portal vein as my guide into the pancreas. We can also use the celiac trunk as well. So I'm just going to follow the portal vein, pushing big vein a little bit down, and then I will lie down onto the pancreas. We can see the portal vein. This is actually the Y-shaped from the body of the stomach, which is actually on the left side is the superior mesenteric vein. Whatever above the junction of the portal vein and the splenic vein and the superior mesenteric vein, the above is the body of the pancreas. So we can see the pointer at the body, and whatever below is the head of the pancreas. So sometimes we can see it also from the stomach. So just the purpose of the exam as the patient on monitored anesthesia care. So we'll just go now to examine the pancreas. So now I'm lying down on the bed, on the body of the pancreas. So here we sometimes cannot see clearly the PD. However, I will just keep the pancreatic tissue at 6 o'clock, and we can see multiple dilated small side branches in his pancreas that make the location of the PD a little bit difficult. However, it could be the one in the center. So I'm just going clockwise torque toward the tail. So we can see a couple of small cysts here at the body, just underneath the transducer. Okay, so there's 2 small cysts here. Okay, and then I'm just gonna go clockwise toward the tail, clockwise, and we can see the pancreas. It's a little bit heterogeneous with honeycombing appearance. So there's some hypoechoic lobules and hyperechoic foci and strands. So we can see here also the renal artery and vein. And if we can put the flow, so we can differentiate between vessels and cyst. So we can see here a cyst just at the distal body toward the tail. It's around, it's actually subcentimetric cyst. I'm just gonna go back again. So we have 2 small, so there's another one here. So I always, whenever we see cyst, we keep it at 6 o'clock and scan it from right to left to make sure there is no any nodules, mural nodules, or any high-risk feature. Is it septated or no? So we can see a thin septum here in this small cyst. So it's basically 2 1 centimeter each cyst at the tail of the distal body of the pancreas. So we can see the kidney down, which indicate we are at the body, and then we will see the spleen just following the tail. There's another small cyst here, another, and then we have the spleen here. Yeah. So we can see the spleen, and there is also another tail cyst. So basically multiple 1 centimeter size, less than 1 centimeter size at the distal body and tail. So all these are cysts at the tail and distal body of the pancreas. So multiple cysts going also with IPMN. Yeah. However, it's not typical for the age. Now I'm just going counterclockwise, trying to go into the genu and then see if there's any cyst in the proximal body. So we can come back here, see.
Yeah, so this patient also has what we call a fatty pancreas, okay, and this happens mostly among obese patients and sometimes among smokers. So it makes the pancreas exactly what Dr. Adel was mentioning, very lobular with multiple foci, making examination sometimes if in the PD, especially if the PD is not dilated, difficult. So the trick is usually to kind of try to find with the point where the pancreatic duct dips down into the head. And now we're going to trace it right now so we can show you.
So this is where the pancreatic duct dips down. So I'll just leave the arrow there so we can see here. It's just going down from the body into the genu, into the head at the level of the genu. And I'll show you that. So here is the cyst of the concern, which is located at the head by the MRI. So we can see the head from here. We will have a better examination of the head at the duodenum. So we'll just go now into the D1 just to examine the head of the pancreas and to see that cyst that we still can see part of it from the stomach. However, the best examination of the head will be from D1.
So it's very important also, especially when there's a lobular pancreas, as what Dr. Adel said. It's very important to know the anatomy, to follow to the tail, to know the spleen, and know your landmarks on EUS. So that's the difference between a full exam of the pancreas as opposed to just targeting the pancreatic head. So it's very important in these cases to examine the full body, head, body, tail of the pancreas. So right now we're in D1, Dr. Adel.
Yeah, so now I'm at the head of the pancreas at D1. So we can see the CBD.
Beautiful.
Yeah, so we can see the CBD, yeah, as Dr. Saad points. So this is the CBD, and then the PD here, okay. I'm just going clockwise, 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 and then both will join into the ampulla. So it's not that clear from D1, however, the best view of the ampulla will be at D2.
Especially that he has a straight duodenum.
So again, during this exam, I really can't see a clear cyst, right? We see multiple small dilated side branches where the pointer is just a little bit here at the center of the screen, but we don't see clearly that cyst. The issue then always with the head, when the CT and the MRI says it's head, sometimes it's head and uncinate. So this is the one here. So we can see it now. I just put the probe a little bit pushed in, close. It's actually at the level of the sweep. So we can see this group of cysts. So this is the largest component here. It's around 1 centimeter. And then what we'll do is we'll have another visual. We can see like another group of cysts here. So what do you guys think that is it like looking more of a cirrus or an IPMN with one macro and microcystic component? We'll have a look also in the uncinate while we go. So probably the scope already went to D2. Yeah, so I totally agree. Now this is another view from D2. So I'm now at the level of the uncinate process. So we can see here the aorta, okay, in the screen, and then I'm just torquing clockwise to examine the uncinate of the pancreas. We can see here the group of the cyst again. So this is now it's more clear in D2 exam. So I think it looked like cirrus in this examination, especially in this view, with one macrocyst like around 1 centimeter here. However, I agree with you, Nawal, the patient with he's young and his MRI showed other cysts. And in the MRCP report, this one at the head communicate to the PD. I mean, we don't see clear communication. It's probably difficult with all these dilated side branches and microcystic, but in this situation, I would probably FNA the largest component, the 1 centimeter here, at least to send it for CEA. Yeah. Because if it is IPMN, that is more than 3 centimeter, it's different from serous cystadenoma, given his atypical presentation. So he's young. We don't want to miss precancerous lesion. So, and there are other cysts at the body and tail, which is going with IPMN, not really cirrus, but the one in the head could be cirrus with IPMN in the body. But it's I think important to differentiate. What do you guys think?
Yeah, I agree.
So, first of all, very, very excellent demonstration of EUS. What machine are you using? What scope are you using?
So we're using the Olympus Mu3 EUS. The new Mu3.
Very nice. The images are coming through very well, although I'll make a comment that if there is one endoscopy procedure in a live endoscopy forum where the two of us are commenting on it, the EUS is one exception where only the operator really knows best what they're seeing. So that's one comment. But having said that, I think we see these images very nicely. The second comment that, and the technique of demonstration was amazing. The second comment is true. The cross-sectional imaging often will report the lesion to be in the body when it's near the head and neck area. It will report it in the head when it's actually in the ulcerate. So only at the EUS will you find out what actually is going on. Third point, I agree, the parenchyma here looks a little bit lobular. He's a young patient. Is there any history of recurrent pancreatitis or any history of alcohol use?
No, actually, not at all. We know the patient pretty well. Yeah.
The other thing that comes to mind is whether he or she has a genetic problem that has led to this, both the parenchymal changes as well as some cystic components. So, with regards to whether or not, what is, first of all, what are we dealing with? I think the pancreatic cystic morphology points towards more of a branch duct IPMN status. I think the main pancreatic duct is normal caliber. The lesion in the head of the pancreas is likely a multiseptate, branch duct IPMN. And so the largest component is not too big. I think the yield from our diagnostic FNA will be relatively small in terms of fluid. And even if the CA is borderline or high, the question then will come is, will you subject this young patient to a Whipple procedure, a total pancreatectomy, or just monitor, right? Because the cyst location is not just in the head of the pancreas. So those would be my comments. I know Khalid, you wanted to come and make a comment. Sorry, I kept going on. I already made your point? Okay.
So yeah, sorry, we're back. I think a very valid point. We were discussing, me and Dr. Adel initially. First of all, I do agree. I think this is a conglomerate of side branch IPMNs, especially that's not only in the head, there's few cysts in the body and the tail that goes a bit against the serous-cystadenoma. And there are no worrisome feature here in terms of pancreatic duct dilation. So I agree. I think that's pretty reassuring as long as the patient continues to follow up regularly. I think a very tailored approach with the patient as well is very important. I would repeat EUS for this patient every year or alternate with MRI. And I think we can, exactly like you said, we would be subjecting this patient to probably a total pancreatectomy, given that also the cyst burden of the body and the tail. Dr. Adel, any comments to respond?
Well,
I agree. I think that, yeah, go ahead.
yeah, no, totally agree. The only thing is, it looked like cirrus, but all the history is IPMN. So maybe, a trial of FNA, if possible, and safe. So, you can see now there are a lot of vessels crossing the cyst. So I'm not going to put the patient at risk if there is no clear window. But if there is clear window, I will probably take a sample if possible, and just to make sure, especially after I talk to the patient, he's a physician actually, and he probably would like to just reassure and make sure that he's dealing with an IPMN. So if possible, I may just take an FNA. If no, then no need.
I agree with you. I think I will revise my comments by saying that microcystic cystadenoma in the head can coexist with a branch duct IPMN.
Thank you very much. I think they will shift to the room, but thank you. If there's any question,